been quite intense in a good way.
Yeah. If we give it another minute, does anybody want to share their highlights from QI week so far? Because it's not all over. But have you got any top tips? Yeah, have you got any top tips though on sessions that you've attended that you think other people should listen to the replays of? Anybody?
So I don't really want to promote one that came from our organisation, but there was one on, but it was just because it was very fresh in my mind because it was yesterday. So the demand and capacity one, and it's not because of the demand and capacity stuff as such, but they had a service manager talking about the difference it had made and all the things that they'd done and how complex it'd been. It was just really interesting hearing things from her perspective in quite a complex mental health service, community mental health service. So I found that interesting. You could skip the theory and just go to her story if you wanted.
Because it put it on triple speed sessions.
Yeah.
And I went to the Anurin Bevan one on I think on maybe the Monday one about coaching, QI coaching, which was really great. Tied in a lot of strategy and some people talking about their experiences of QI coaching. So from all perspectives, you know, managers, people who are coaches.
Have a look at that one then.
Really worth catching up on.
Fantastic.
Amazing.
Brilliant.
And we've had some lovely local fun as well, which has been great. So yeah, it's been really enjoyable.
Good.
Brilliant. And can I just ask, we'll start now, but I just want to just check with you guys. How can you just put your hands up if you have accessed this session today using the flipped book? And the alternative being that you've accessed it via an invitation sent to you. I'm just wondering, for Anita's purposes, the proportion of people that have got it from the flip book versus the proportion of people that have got it from the calendar invite and signing up to it.
So all the other sessions I've used a flip book. This one, obviously, because they were worried I might not turn up.
Yeah.
Went in my diary.
Yeah. So it looks like it's about half and half, maybe just over have got it in their diary. So yeah, so I sent out a link to sign up. So it looks like about half and half. So that's quite interesting, and it's just worth bearing in mind, really. So so yeah, that's for you. So I think it's probably time to start. Welcome everyone, and thank you for joining us for this session. It is being recorded, so if you would prefer not to be in that recording, keep your cameras off and pop comments and questions into the chat box rather than coming on to the audio. If you could just make sure you're on mute if you're not one of the presenters, that would be fantastic. And do pop in questions, comments, reflections, etc. into the chat box as we go along. Let's make it as dynamic and engaging as we can. My name's Andrea Gibbons and I work at Somerset NHSFT. And Anita asked me to run these sessions this week as a follow-up from the Evidence for Quality Improvement project, where we ran spotlight sessions looking at the improvement approaches that different teams across the country take to quality improvement. So rather than looking at specific projects, very much looking at how we do improvement. And those videos are all available on YouTube, and we'll share that following this as well. I should shout out to Q, because Q make everything that either QI, the QI Hub and 100 Voices are doing possible. So thank you to Q. So what we're really here to talk about is the guys who are presenting today. So we've got the Academy of Research and Improvement from Hampshire and the Isle of Wight Healthcare NHSFT. So we've got Tracy, Sarah, Carl and Anita, and I'm sure they will introduce themselves shortly. They did do a previous spotlight session, so if you want to hear an earlier sort of episode of their story, again, that will be links to it as part of the video when this goes up onto YouTube. So if you do want to hear an earlier iteration of their story, then that is publicly available. But I think without further ado, let's hand over to Anita and the team, and massive thank you again to Anita as well for everything related to QI week, because it would not be happening. We would not be doing this or anything else we're doing this week without her and the energy of the team working with and supporting her. So thank you, and I'll hand over to you guys.
Thank you. I mean, I think it's fair to say that these spotlight series have been going a lot longer than QI week. So, yeah, take a bit of the credit, Andrea. Well, we'll introduce ourselves first, shall we? So I'm Sarah Williams. I'm Director of Research and Improvement for our newly formed Hampshire and Isle of Wight Healthcare. We're a community and mental health organisation on there, but quite obviously on the South Coast because it's the Isle of Wight. And Tracy.
Morning, everyone. I'm Tracy Herald. I'm a member of the Side by Side team. We're an enthusiastic group of service users and people with lived experience of accessing health and care services. And we work in partnership with the Academy to support their quality improvement work.
Hi, everyone. I'm Anita. Obviously work at the Academy in improvement.
Hi, I'm Carl. I'm Head of People Participation and I lead on working alongside people across improvement and research.
Brilliant. Okay, so we have an integrated approach to research and improvement, and that's what we are going to talk about today. So I'm going to share the right, should be up.
Yeah.
Okay, so just a little bit about us. So we quite perhaps pompously call ourselves the Academy of Research and Improvement. We are an integrated team that help people get involved and drive research, improvement, clinical effectiveness across our team, which involves a library service, participation team, research, all clinical research. We've got an innovation arm. So it's that kind of bucket of improvement tools as we see it. And we deliberately gave ourselves a brand because a few years ago we were finding that it was quite difficult to have an identity and be very visible about the support offer that we had across the trust. So we had a comms person who was brilliant, and she suggested that we get ourselves a brand. And so after lots and lots of talking and not decided, we did end up with the word Academy because its official kind of definition is all about learning. And the reason we've integrated it, so it wasn't a master plan, but it started to become a master plan after a little while. So we started with research. And then it was just really obvious to me back in the day that it was really quite difficult for people in our organisation to get the help that they wanted to get because they got bounced about. Now, in my experience, most of the people, almost all of the people actually, with a very, very, very rare exception of people who work in any health and care system, are brilliant people. They're all there, you know, wanting to do the best by people, wanting to work really hard, wanting to provide really good care and support. But those roles now are increasingly quite tough. People have, you know, quite a lot of pressure at work. And so if you're asking them to do additional things on top of the day job, such as continuously improve or assess effectiveness or get involved in research, that's a bit of an ask. And so it's our job, we think, to make that as easy as possible for people, to make it accessible and enjoyable. So what we've tried to do, and what we're trying to do in a kind of a new organisation now, is to make sure that rather than us holding sort of power in the activity in our teams, is to empower, enable, and engage with teams across the trust and individuals, and also beyond the trust, so people who work across a pathway or a collection of care, to get really involved with improvement in whatever guise. And it might be that they start with something small like an audit. It might be that they're very academic and want to do the research. But the important bit is that they can enjoy it and feel really empowered and enabled to do things with the skills. I think there's often an assumption that anyone can do improvement, and they can, but you do need some help to do it and to build the confidence. And what we're trying to create, and we've recently got a paper through our board around a learning health system, which I'll talk a bit more about it, where all these things interconnect in a really sort of clear way. And then eventually, given that we're community services, we want our services to be able to evidence that they're effective and that they're continuously improving, which brings a kind of pride, but also is really helpful in this environment where we're trying to shift things out of hospital and into the community. And so the research link is very much about building that evidence base for really high quality out of hospital care, why it's better, how it's safe, the outcomes that you can get, and so on and so forth. So as I said before, that's the approach, that's it. Focus on making it easy and accessible and useful in service, whether that's a big clinical trial or a small scale improvement project at a ward level. And the way we try to put it together in a more theoretical way, and this is not seamless, and I did take the initial idea from this from Emma up in the Wirral, so if she's on the call or anyone knows her, it's all credit to her really, is to think about understanding how effective a service is, or how effective your care is. And there's lots of different indicators of that. And if you get a good enough idea of how effective something is, then you will know about areas that you want to improve. So if your waiting list is too long, that might be an area. If you're getting complaints about communication, that might be an area, and so on and so forth. But you have a sort of systematic way of looking at where the gaps are and prioritizing some of the areas of improvement. And then you start testing through our sort of quality improvement systematic tests of change on whatever scale around testing things to improve and making sure that you've got some evidence about the impact that that has. And there's lots of work that you can do around that and approaches. We've got co-production, there's quality improvement, there's demand and capacity, so on and so forth. And then when you know that something's working and you've got a good evidence base, you know it's more effective, but you should then be able to write that up, whether you write it up fairly informally or whether you put that into a formal research paper and write it into a journal. It doesn't necessarily matter, but you are sharing learning and best evidence. That best evidence then contributes to the how effective am I against it, and then kind of round and round it goes, not obviously in a seamless circle, but that's the very pared down theory behind it. And then within that, I suppose the approach we take it back and think, so what do people need for them to be able to do that? So they'll need knowledge and skills, obviously. You need some time to do it, some support. You need to be able to learn from others. You need the infrastructure in the trust to make that possible, clarity, a culture in which kind of learning and improvement and testing, and sometimes that not working, being possible and allowed and sort of celebrated. And sometimes a little bit of resource, even if that resource is time. And I've just gone into a bit more detail here around sort of how the streams of work that we have within our little, not so little anymore, academy team. So if you're looking for the best available evidence, we have a library service embedded within the team now, and since we've integrated that, now the full Hampshire NHS library services are hosted by us, which is brilliant. And we have knowledge specialists and people with different skills in that to help you learn how to use the literature, but also support with sort of rapid evidence reviews and so on and so forth. There's a clinical effectiveness or learning and effectiveness stream, which looks after all of our clinical audit. There's evaluations, there's NICE and other clinical guidance. There's kind of national audit, POM programme, our clinical network, so on and so forth. And then quality improvement, traditionally, we've changed it more into continuous improvement as a result of NHS impact. So it's a bit broader. But if you're there early in the week, there's lots of programmes through that. So there's quality improvement, but there's demand and capacity. We have co-production in there. We have leadership, we have special interest groups to network people across quite a large trust. There's an innovation stream which is growing. We're trying to do a lot of work about data literacy, increasingly in confidence around using data and interrogating, and then also trying to link into some of the transformation programs that are happening and put a bit more of a systematic approach and improvement principles around that. Then we also look after research. So I think one of the more unusual things about our team, and I know Somerset actually do the same, is research is integrated in. It doesn't sit as a standalone team or service, and that's both hosting trials, which for the benefit of people who are using services, but also driving research. So trying to build capacity with people to use research in their roles in their careers, rather than only clinical academic pathways, because there's all sorts of things that you can do. And we support people with publication and involving patients recruiting into studies. There's lots of career pathways and different job roles that you can have, or just different ways to get involved. And then finally, all of this is done with a very, very sort of strong and non-negotiable focus on working in partnership. Now, whether that's working in partnership with people out in the community, or more importantly, or as importantly, people who are using our services. So Tracy's going to talk about how some of the ways in which we do that, but we have people using our services in all of our training programs now, and threaded through all of these streams of work as a kind of not only role modeling, but making sure that we're doing what we should be doing. And then just quickly before I hand over to Tracy, we take an approach which is sort of incremental and continuous, recognizing that people have come in with different levels of experience. So all of our training or support programs will sort of build up on skills. So you can come into a short introduction or getting started for a real beginner. We then have cohort programs, so you'll learn doing a project over sort of 4 to 6 months. We have leadership programs linked to improvement and research, and then an increasing number of what we've called special interest groups. We played around with communities of practice for various reasons. We dropped those and went with we aligned with the Health Foundation's words, which were special interest groups and networks. So we've got one for demand and capacity, linking people across the trust. We've got one for co-production. There's an early careers improvers group, and so on and so forth, to try and get connection and sort of peer learning across. And that is very deliberate because of the knowledge that we have from the Health Foundation and others on connected leadership, and highly networked organizations tend to be the most effective organizations. And then there's lots of different offers within that, whether they're workshops or drop-in sessions, coaching, bespoke support, so on and so forth. And this is a slide which doesn't really work. We've been messing around with how we show our programs, but that sort of shows the different things we've done. But things we covered that in the week, I'm not going to go into that. And as I've already said, try to really connect people up so that we're not working in silos in teams, but pulling people across, which is why when we do our programs, we ask people to come in person and as a bit more of a team. And we will mix up people from different areas of the trust often, so that people can learn and see how other people are doing things. And the impact of that, we've been doing this now for, I don't know, 7 or 8 years, maybe, with the pandemic in the middle, and it really does work well. For so there'll be people who are interested in quality improvement, and that's very accessible quality improvement, isn't it? But that opens the doors into research often, or people who are doing research and you think actually there's much more pragmatic ways of doing this. You could do this through improvement cycles instead of trying to do a big trial. And so there's multi-directional kind of multidisciplinary programs of work that start to fit together and build up for a service, so you ripple effect out, which is great. I was going to say we're moving closer to being really quite a good learning organisation, but we've just merged, so we're now 3 organisations in one, and it's hard. We don't really know. We're at the very early stages, shall I put it that way? So I think it's fair to say we've probably not gone backwards, but there's a lot of different cultures and different ways of working that we need to get around, but that's still very much the ambition. And then we want people to have fun. We want people to have their improvement days to be something that they really enjoy, and a bit of time out. We don't want to be adding to the pressure. So I'm going to hand over to Tracy now, who's going to do a bit of a focus on the partnership working that we do in our wonderful side-by-side gang to keep us on our toes.
Great, thanks so much, Sarah. So I'm Tracy, and as I mentioned, I'm part of the side-by-side team. We provide a patient and public partnership with the Academy, and we work together to encourage and embed a patient perspective in the Academy's work, as well as hopefully shaping a culture of patient involvement across the wider trust too. So side-by-side members engage in a wide range of activities to support the trust and bring a patient perspective to the work. These include working alongside academy colleagues to support the delivery of training programmes, helping to bring patient voices and experiences into the room. We also co-design and deliver training and support to practitioners to help build their knowledge, their skills and their confidence in patient involvement and co-production. We work closely with researchers to make their studies better and shape how research results are shared so that everyone can understand them. We co-design and deliver the annual conference and other academy events. And we also, of course, join recruitment panels to support the Trust's employee selection process. We're really proud of the genuine partnership that we're building and the ways in which we're, I think, continuing to push the boundaries of patient involvement to genuinely integrate patient voices and experiences within the Academy and the wider Trust. And to help bring this to life, I'll share a couple of examples of how the side-by-side team are working to embed patient involvement in key programmes of work. So the first example is our work on co-production. So we've developed a co-production training programme, and I think when we started developing it, we really wanted it to feel genuinely collaborative from day one. So we brought together side-by-side members and academy staff to co-design the programme. We wanted to shift the way we work, I think, so that co-production isn't just a nice idea or something that we do occasionally, but actually becomes part of our culture. We want it to be a natural way of working, built into how we plan, deliver and improve our services. So that involves really walking the talk, as Sarah says. It's really about role modelling meaningful patient involvement from day one. It was our view very strongly that you can't train and ask others in your organisation to involve patients if you're not living that commitment yourself. So side-by-side members and the Academy team met regularly, most of the time in person. Those meetings were about a space to plan, to reflect and to keep adjusting what we were doing. It wasn't definitely about getting it right straight away. It was about learning together. And this was an approach that we encouraged practitioners to adopt too. It's very much learning by doing and adjusting your approach as you go.